Hi, thank you, ladies and gentlemen, for standing by. Welcome to the Disability Competent Care webinar series call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Instructions will be given at that time. Should you require assistance during the call, please press star then 0. I will now turn the conference over to our host, Chris Duff. Please go ahead.
Thank you, Karen. On behalf of the Lewin Group, the Institute for Healthcare Improvement and Disability Practice Institute, I would like to thank everyone for attending the 7th in our series on disability competent care. As Karen stated, my name is Chris Duff, and I'm the Executive Director of the Disability Practice Institute. First, a few quick things about this webinar platform. If your slides are not advancing, please push F5 on your computer keyboard, and that should get them moving again. Please note the 2 icons circled at the bottom of the screen. The one on the right allows you to print a PDF and PDF of the slides for this presentation. The red one on the left is for questions. If your question is about the technology, someone behind the scenes will respond in real time. If it is a question for the presenters, we will be compiling them throughout the webinar and will return to them at the end. As I said, this is the 7th in our series of 9 webinars being presented through the fall. All the webinars are recorded and available along with a PDF of the slides at the link on the bottom of this slide. Today, we are focusing on coordinating flexible long-term services and supports. We will conclude the series in early December with presentations on building a disability competent provider network and participant and provider readiness. Each presentation will reserve 15 minutes for Q&A at the end. I'd like to step back for just a moment to give you the genesis of this series and several other tools for integrating healthcare services for dual-eligible populations. The Lewin Group, along with Institute for Healthcare Improvement in Cambridge, has a contract with the Medicare and Medicaid Coordination Office, commonly called the Duals Office, at the Centers for Medicare and Medicaid Services. This contract is to provide tools and technical assistance to providers that are seeking to integrate and better provide care for individuals who are dually eligible. We would like this webinar series to be as helpful as possible, so please submit questions in writing, and we will additionally open up the phone lines at the end of the presentation for live questions. We're also asking participants to fill out a short survey at the end of the webinar, where we will be asking for feedback to make sure this series and our other efforts are meeting the mark in terms of what you need. Please also send us your ideas for future webinar topics and content, either at the end of the survey or to any of the email addresses listed at the end of the presentation. Today's webinar will be presented by 2 clinical leaders at the Independent Care System of New York City. ICS was founded in the late 1990s and has been partnering with thousands of persons with disabilities and their providers to manage long-term services and support. In that time, they have demonstrated national leadership in developing unique and creative services tailored to working-age adults and seniors with significant disabilities. Their experience, combined with that of a few other pilot programs across the country, served as the model for the description of disability competent care that we've been referencing throughout this series. Jean Minkel is Senior Vice President for Rehabilitation Services and has created multiple programs to support the mobility and adaptive equipment needs of their participants. Rachel Stacom is Senior Vice President for Care Management at ICS, where, among other things, she created their multiple sclerosis program, which has been recognized by the National MS Society as a Center for Excellence in Long-Term Care. We've asked them to share their experience in this webinar series so others can learn and build upon their expertise. Before turning this presentation over to them, I wanted to provide some context for integration of long-term services and supports with primary and acute care medical services. In this webinar series, we are specifically focusing on persons with disabilities who are eligible for Medicaid and or Medicare. When we speak of integration in this series, we are referencing the integration of the financing and benefits of healthcare, Medicare and Medicaid in particular. We are also referencing the delivery of healthcare services, specifically acute, primary care, and long-term services and support. While both programs provide for health care needs, there are significant differences in origin and focus. Medicare is funded by the federal government and is an entitlement program for those 65 years of age and older. Persons under 65 can generally become eligible for Medicare once they are deemed permanently disabled. Meanwhile, Medicaid is funded by both the local, state, and the federal government and is an entitlement program based on need and income. It covers children, pregnant women, parents of eligible children, seniors, and individuals with disabilities. Most importantly, though, in terms of benefits, Medicare covers primarily physicians and hospitals with their related tests and procedures. Medicaid, on the other hand, covers all that Medicare covers, plus long-term services and supports. While this appears comprehensive in nature, the differing funding sources, populations, and priorities has resulted in highly fragmented care. For example, Medicare only covers a problem once it occurs, resulting in lack of attention to prevention. This has in turn resulted in the occurrence of avoidable conditions. For many persons with severe disabilities, over 50% of their hospitalizations are for preventable conditions, such as skin breakdowns, urinary tract infections, and respiratory infections, as will be addressed by our speakers. The dual demonstrations going on across the country are being designed to fully integrate the financing and benefits and consumer protections of both programs, focusing on the triple aim of improved health care, and controlling costs. They are designed to enable plans and providers to focus on these goals by removing the silos of care and financing that have created the dysfunction state. Now I'll hand it over to Rachel for the presentation.
Thank you very much. And thank you, Chris, for asking us to be here today. I always think it's better to start with a real-life story to kind of exemplify why we think the model of integration between long-term care and home and community resources with acute care is important. So I'm going to share a story about a gentleman named Peter that is cared for in our program. Peter is a 48-year-old man who has multiple sclerosis. And due to his condition, he has lost the ability to move his lower extremities. Despite this, Peter is very active, and he uses a wheelchair to get around in his community. Unfortunately, recently, Peter was hospitalized for 10 days because he has what we call Neurogenic Bladder, which leaves him prone to urinary tract infections. And unfortunately, his urinary tract infection was detected very late, and he had urosepsis. So he was in the hospital for 10 days, and during this hospitalization, he developed a pressure ulcer, which very commonly can happen, especially in people who do not have sensation and don't really, their bodies don't, we talk about biofeedback, they don't have the ability to tell them when they should change positions. So Peter has a pressure ulcer now, and during this they picked up that he had hypertension. So Peter's ready to go home, and they put him on a diuretic to treat his hypertension twice a day. I think it's important for us to think about people with physical disabilities when we're creating treatment plans for them. And when we start and we're looking at someone like Peter, we need to remember that although his baseline is already being physically disabled, there are different levels to that disability. And that it can still progress, especially someone like Peter who has multiple sclerosis. That is, it can be a progressive neurologic disease. So Peter is ready for discharge, but his abilities that he had beforehand are now different now that he's ready for discharge due to what happened in his hospitalization. And as healthcare providers, we need to begin to look at the impact of his new status, what services he has in place or he had existing in place before he came in, and what recommendations are going to be made for his treatment plan. And for people with physical disabilities that rely on the community supports, we need to determine, is the current treatment plan feasible with Peter's existing services? So if you look at Peter, and we know that he's had a decrease in function due to his recent hospitalization. He was weaker than he was going in. Does he need more help? And he's now being put on a diuretic to treat his hypertension, and he's going to get in, and he's going to have to go on the toilet and get off the toilet more often. The other thing is that we need to heal that wound, and moving to different moving to different surfaces can also impair that, and also just the moving itself. So it's really important that we take this all into context when we create a plan for people. And we're going to touch on those specific factors a little more down the line in our conversation. So the next slide talks about how we view integrated care at ICS. And for those of you who have been introduced to Maslow's hierarchy before, this may look familiar to you, although the pyramid is a little bit different. In Maslow's hierarchy, it starts with talking about basic needs, which is on the bottom where we have healthcare, and we're talking about really necessities to live, such as air, the ability to have food to eat, and water to drink. And at the top of the pyramid in Maslow's hierarchy is self-actualization, where someone is fulfilling their potential. Here at ICS, we view that similarly, meaning if someone doesn't have their health, if they are ultimately sick, we're not going to get them anywhere. We're going to have to address that illness, and we're going to have to support them through that before we can do anything else. As we move up the pyramid, once we have them stable or healthy, we need to get them moving. And so, as Chris said, we are a disability, our foundation is in serving the physically disabled. Without the right equipment, people, again, are going to be confined to home. And Jean's going to talk about that a little bit more. And then finally, once we can get people healthy and moving, then they can get into their community. And that is our ultimate goal at ICS, is to keep people at home and in the community, however they like to define it. Some people like to participate in social activities, and some people are more introverts and like to hang at home and watch Jeopardy, and whatever it is for them, we want to make sure that they have the opportunity to do so. So what is long-term care supports at ICS? And for us, the biggest service we provide is personal assistance. It's also known as home care, aides, personal care aides, personal assistance is listed there. So that is the biggest service we provide, and what we frequently hear from our membership or the participants is that they are their arms and legs for them when their body is unable to do it for themselves. So using the home care worker really helps these people stay at home. Also, skilled nursing. Some people have needs that create a need for that service on an ongoing basis. We have adult health programs for people who prefer to go out and get those needs met in the community. Home-delivered meals is also an option for people who would prefer to use that service instead of a personal care aide being there. A lot of times we use that in combination here at ICS. Rehab therapies are really important. Jean's going to talk a little bit about that, but I think in the acute care world, we look at rehab as restorative. I think in long-term care, we very much focus on maintenance and how can we get those experts in the home to help get the people either the equipment or learning the tools that they need so that they can maintain their current level. And as we move into medical equipment, again, we spoke of that before in mobility, and we'll touch on that in a little bit. And the rehab technology touches on that as well. Without transportation, we can't get people anywhere. And So we use that often to get people to medical appointments here at ICS, and we are very lucky in the New York City area to have a paratransit system, which we call Accessoride, to get people to and from any social activities they want to participate in. Home adaptation is really important. Jean has a great example that she's going to show you guys where I can personally say before I started at ICS many years ago, I didn't realize how one single step could really be a barrier to welcoming someone with a disability into a facility. And making sure you're connecting people to the right social programs, because we all need social support in our daily life, and sometimes we come into this world with it, and sometimes we have to create our own social supports out there in the community. Some additional services that in our Medicaid system is covered is podiatry, optometry, nutrition, audiology, and dental. And that's not always considered in long-term care services. Here in New York it is. So we want to make sure that our members have access to that.
Excellent.
So talking again about the gap in integrated health care, it is a very interesting world we currently live in regards to long-term care and the traditional medical model. This first bullet that says, how does the doctor in MS clinic deal with the person who is accumulating disability, comes from my own personal experience. I have a specialty in multiple sclerosis, and I was speaking to a very dear friend of mine who's a neurologist and a very caring one. And I said to him, when do you bring up long-term care services? When do you offer? When do you see how they're managing at home? And he said to me, I don't, because I don't know what to do if they say they can't manage at home.
I'm a physical therapist and worked in acute rehab, and in that setting, the patient, along with the therapists, physicians, nurses, and family, all worked really hard to create an opportunity for someone to be discharged home. The goal of acute rehab was to give somebody the functional skills to be able to compensate when there was a loss of physical ability. The experience that we had was the gold standard was discharge to home. And in my experience here at ICS, starting back 10 years ago, a real awareness struck me that getting home is where the real work started, and that it's an opportunity to really take stock of what environment is the person trying to function in. Often acute rehab is in fact idealized. It's the best situation. When someone gets home, it's the real situation. So I want to move to the next slide, because one of the things we noticed is as professionals work in different environments, it's important to identify if there are gaps in communication. And Chris mentioned early on that the silos that get created depending on the environment people are working in. Through our experience here at ICS, we've identified that talking to other professionals who are functioning in other environments, it's really critical to ask a very important question, which is, what is the best way to communicate with you? We find when we reach out to physicians' offices, is it voicemail that works? Is it fax? Who uses the text versus email? When you ask that question right up front, it takes a whole level of frustration away when one party's using email but another party's using voicemail, and the interpretation is nobody gets back to me. So up front, identifying what is the preferred method of communication is so important. And the critical nature is each of us are working in our own environment. In the process of integration, we're trying to break down the walls of those silos. And to do that, we really have to have a mutual understanding of what is each person's role in the coordination of care. The home care worker has a certain set of roles. How does that work with a therapist that comes in from the Certified Home Health Agency? How does that therapist interact with the nurse practitioner from the doctor's office? If there is a discussion of an understanding, what comes and is created is then mutual respect. How can each person work from their strength to provide the support that persons with disabilities need to, in fact, be successful in living in the community? What we can tell you after 12 years of service provision is not one person can do all of this. And supporting our participants is really based on mutual understanding, which leads to mutual respect. Next slide. Here at ICS, that process begins with actually a requirement of our program as a managed long-term care program that there is a comprehensive individualized assessment that's conducted in the home of the client by an RN. That initial assessment is done as part of the intake into the program and then is repeated every 180 days thereafter. Our experience in focusing on people with disabilities is that the functional assessment provides us a good understanding of what activities of daily living or instrumental activities of daily living somebody may need assistance with. But we've also found that there are some focused assessments that have really helped us hone our interventions and guide our participants to some, as Rachel referred to, healthier lifestyles. So we look at focused risk assessments around pressure sore development, respiratory distress, and urinary tract infections. And I don't think it would surprise anybody that these are areas that if we manage early, we can avoid hospitalizations, which is why we really are looking at where are the risks and how can we intervene before we have a real problem. Next slide. From the comprehensive assessments, the individualized care plan is developed. And the care plan really is initially the creation of a problem list that's generated from the assessment visit. It's both problems identified in the functional assessment as well as our focused assessments. And ultimately, we look to say, for this particular participant, what are our concerns around health, mobility and function, and what's the ultimate impact on that person's community participation? It's really important to understand that the problem list is generated, but the care plan is really a result of collaboration with the nurse, social worker, and our interdisciplinary team members who work with the participant to establish a prioritization of problems. What we've understood is we're working with people, and 10 problem list is overwhelming for anybody. So what's the priority of the participant? How can we provide some education, some insight as to what their risk factors are, and really have a discussion about what we found in the assessment and what is the person interested in addressing. It's really important after the education of the risk factors to really have a healthy respect for the dignity of risk that's exercised by the participant. Someone who's lived with their disability for 20, 25 years is very articulate about that which they want to address and that which they're just comfortable living with. We look to really focus on identifying the interventions that the participants want to engage with that we can focus on in a 6-month interval. And the 6-month interval is chosen for both the reason that we have to reevaluate every 6 months, but it's also long enough to see a change, but not so long that it feels so overwhelming to the person that they can't engage in interventions that can make a tangible difference in a relatively short period of time.
Next slide. So this is Rachel back again. And I just want to pause again to reiterate what Jean said, which is we are here to support the participants in their goals and priorities. And sometimes I think as healthcare professionals, this can be a little challenging for us because we know, sometimes we think we know what is best. And to Jean's point, kind of having that discussion and allowing people to say, this is important to me, it should be the priority. That should be number one. And where we can step in as part of their interdisciplinary team is to say, well, this could be important too, and I want you to understand why. To Jean's point of the dignity of risk, it should be that people are making informed decisions. And sometimes, given our population, especially here at ICS, where the literacy level can be very low, you want to make sure that people really understand why it's important to us. And once they do, if they choose not to do something, then we have to allow them to do that. And I'm going to talk a little bit more about some alternatives we can step in and do in those circumstances. But at ICS, the number one person, as I said, really identifying and prioritizing is the participant and their family and friends. And if we all think about it, that's who we go to if we need to make a decision. And then we go to the experts that we know, and it's the same here at ICS. I'm a nurse practitioner. I will tell you that I get daily phone calls from family and friends asking me for my expert opinion. So that's what we do. Sometimes I don't feel like an expert in certain areas, but that our members should have access to that, to people who know healthcare and should discuss it with us when we need to, and that we should share our information with them. So the IDT at ICS is comprised of nurses and social workers and care management coordinators who really make sure that the services that are initiated by the member or the care manager actually go into effect and are delivered to the member's satisfaction. Paraprofessional coordinators, we have that separate from care management coordinators because, as I said before, it is the biggest service that we provide, and it is, I want to say, I'm like hesitant to say, but it is one of the most important services we provide. So having a dedicated person on each team that makes sure that all of the participants on that team receive coordinated home care is very important. And lastly, we have a role called the senior aide, which is in new development here at ICS, but that is someone who is a specialist in home care and has been a home care aide for at least 5 years and has shown leadership skills, and that they have come over to ICS to really help our members who are having challenges in care delivery. Whether it's because they cannot stabilize their home care or because they're having some challenging situations, whether it's medically or due to behavioral health issues, where care cannot be delivered consistently. So the senior aide is really going in there with their specialized eyes and saying, okay, this is what I'm assessing. And they're really in service of both the member and the home care aide, and to mediate what's going on in the home. Next slide. So in addition to the IDT, the team at ICS, we have resource supports. And these resources are here because, as Jean said before, our members have certain secondary conditions that they're at risk for. And we believe that also that they need this specialized care in order to achieve their goals. So wound care we have a group of wound care nurses. We have 3 wound care nurses that will go out and do visits and follow people who are either at high risk to develop wounds or have an active wound. We have rehab services, which Jean will talk about. And we also have a group of social workers and nurses that are helping people who are currently in transitions. These people are in transitions we're defining as they're moving from a facility, whether it's a hospital or a nursing home, back into their home. Sometimes they can also be going from a hospital to a nursing home, that there are specialists that are there to help the member with the transition and also to make sure that they are aware of what they need to do to maximize their health. One of the other things that we do is we have here is a resource for consumer-directed care, and that our members or the participants know that they have an option for consumer-directed personal assistance where they have the opportunity to hire and fire and train their own aides. That is something that we use often here at ICS for members who would like to direct their own care and they don't want to work with a licensed agency. It also is a great choice for members who require skilled services that is out of the scope of practice for an aide. And really, we all have a shared goal in ICS, and this is a really important bullet to me because we're all working together to keep the member at home and healthy. So going back to health, mobility, and community, that is always our three goals that we're focusing on here at ICS. And although sometimes we might want the member to change some behaviors, sometimes that's a pretty hefty thing to do. So if we have a member who comes in who has been a smoker for 20 years, our ability to get them to stop that behavior is extremely limited in the short term. And what we use here is the risk reduction strategy where we work with the member to say, okay, so we acknowledge that you smoke. We also acknowledge that you need a home care worker, and how can we adjust that behavior so that either the home care worker isn't exposed to that, so can you smoke outside of your home care hours, or can we change the environment, like you go outside to do that so the home care worker isn't involved. So isn't exposed to that. So risk reduction is something that we use often here, and I think, it's in the also short-term steps through a long-term goal. Sometimes you'll get people there, but it's an intermediate step. I think that, Jean talked about the dignity of risk, and we have to respect that people can make informed decisions that we don't think is right for them. I always say to my staff, if someone followed me around 24 hours, I'm sure I would be called non-compliant. We make bad choices sometimes. We have the cheesecake after the steak. I think that is we have to allow that our members or the participants to do the same. So as we move on to talking about some of these specialized services a little bit more, again, I'm going to talk about the aid because it is essential. This is really the service that we can offer to our participants to help them stay at home. Without it, they wouldn't be able to. And there is actually a study that's done by a gentleman named Robert Buchanan looking at people who had to go into the nursing home and that had multiple sclerosis, and they tend to go in at an earlier age, and the key indicators for that are becoming incontinent. So when you look at the needs of our membership and the role that the aid can play, those are subtle but big changes in going from relying on family support to needing a paraprofessional in your home. These people are also, for us as healthcare providers and in long-term support, they have the most contact with the member. Even if we contact the member every 2 weeks, it is still not the same as going in there every day or 3 times a week or 2 times a week to see what's going on. I think we have not done a good job so far in maximizing this role. If we can give the PCA some education and train them and allow them to go, they can be the first to really connect back with us. And I will tell you from personal experience, we worked with one of our preferred home care providers to do some training on multiple sclerosis and what can occur due to the disease process. I will tell you that the home attendants were hungry for knowledge, And I got the most interesting messages, voicemails after the training saying, I know, I just want you to know, I'm giving you an update on Miss So-and-so. She's walking a little weird. Okay, bye. So they're able to apply this, and I think we need to set up systems where we can continuously get their feedback on what's going on in the home. So as I said in the last bullet, is really talking to the ability for us to work with this consumer-directed program and allowing the member to have control. And in some of our members who are, for many of our members who are very dependent on care, they live in a world that is beyond their control. So when you can give control back to them, it can make a huge difference. So we need to really make sure that they know that that's an option for them should they choose to elect it, because there are some, there are other things that they have to identify the people and hire them and train them, but that it is a great service for people who want to maintain some control over their day-to-day life. So now we're going to move to talking about the risks and how we try to address these risks in people who are physically disabled. I will tell you that I recently was writing an article for looking at collecting morbidity and mortality statistics on people with multiple sclerosis, and the 3 reasons that people died who had MS were due to wounds, pneumonia, or urosepsis. So why that's very disturbing, because they it is preventable. It's also very hopeful, because there are interventions that we can do to prevent them from occurring. So when we look at pressure ulcers, what we do at ICS is kind of twofold. One is, can we identify those at risk and prevent it from occurring? So to do that, on all of our members, we perform a Braden nursing assessment, and the Braden looks at 6 risk factors, one being sensory. Can they feel their skin? 2, moisture. Are they wet? Because that actually makes for an environment for the skin to be impaired. Are they active? Are they moving around, or are they immobile? Are they able to change positions once they're in either laying down or sitting up? Are they eating well? And how do they transfer? Is there friction or shear? So is their skin kind of being pulled when they're going to move to transfer? So we perform that on all of our members at every nursing assessment. So that's being done at least every 180 days. It will also be performed at any if the participant is having a changing condition. The thing that always gets me with the Braden score is that we have to remember the lower the score, the higher the risk. It's kind of opposite to our nature, but the lower the score, we really want to make sure that we're putting in interventions to reduce the risk. So what does that mean? How do we reduce the risk? So here on the next slide, we talk about some interventions that we train our staff in doing. And I just want to pause for a minute to say that the nurse performs the assessment and says if someone's at risk or not. But the interventions are all coordinated by a social worker. And I think that's really important, because it goes to show, and our numbers in our reduction in the ability to prevent wounds are below the national average, to show that people do not have to have a medical degree to be able to really improve health outcomes. So here are some things that we do at ICS. We offer everyone an inspection mirror. So it is a mirror that is kind of on like a hook that can allow someone who doesn't have the ability to look, kind of turn their body around, to give them a view of the area. It's commonly their backside that they're looking at, to see, is there any redness there? We also offer our members a moisture barrier lotion to put on. And this is really important for our members who are incontinent. Jean will talk about this a little bit, but that we do some pressure mapping, which is it always reminds me of topography, but it is a device that our members can sit on, and it will show some areas that have high pressure to them, and then we try to get them a support surface, a seating cushion, whether it's a Roho or some type of gel or air device to reduce that pressure, and either their cushion on their chair or on their bed to reduce that from occurring. And finally, one of the biggest things I think that we do here is really education, and that is stressing the importance of members repositioning themselves, whether it's while they're in their bed to turn in position, or it's to shift their position while they're in the wheelchair. And this can be as simple as for members that are paraplegic and have the ability to do it themselves, leaning forward, sitting in their wheelchair. And sometimes if they don't, you will see wheelchairs that have the ability to tilt for them, so to recline back and kind of lift their legs up so that they are adjusting the pressure off of the areas that can cause breakdown. And next we're going to talk about a respiratory impairment. Again, I will say that this is a very devastating area should one of our members who is functionally impaired to the level of being a quadriplegic. This is something we worry about greatly. Pneumonia, once they get it, can be very hard to recover from. So again, we look at who's at risk. We very much focus on our quadriplegics in this area. We want to make sure that they understand seating and positioning again. You should be, if you're eating, your head should be up and elevated at 90 degrees. We want to make sure that they get their flu shots. And for those, especially the quadriplegics, that they've had their pneumonia vaccine. We ask, are you having difficulty swallowing? And if they are, or if we notice them, and if we ask them to take a sip of water, if they say that's something that they do on a regular basis, we want to make sure that they are doing that correctly. And sometimes we'll get a swallowing evaluation for that. And if needed, there is a device called a cough assist where they can, it helps them, for those with an ineffective cough, to expel air by projecting a bolus of air in there. And finally, talking about urinary tract infection, we are looking at people who, as I said before when we were talking about Peter, have a neurogenic bladder that require catheterization. Are they doing that correctly? Are they doing it often? And we want to observe their technique to see if they are using clean technique and not introducing bacteria, that unwanted bacteria, where it can be prevented. And then there's also a device called an introducer catheter, a tip catheter, where it avoids the dirtiest part of the urethra, which is the lowest, like half an inch to an inch, and it threads the catheter up to avoid that area. So those are some things that we're doing here to address those three areas. Now I'll turn to Jean.
So looking at the next slide, in addition to the risk factors that we've talked about in terms of pressure management, urinary tract infections, and respiratory, the folks that we originally worked with physical disabilities, it was quickly identified that having them be able to access the appropriate wheeled mobility device was one of the most important things on their problem list. And the management at ICS reached out to a group of therapists who had an experience in recommending individualized equipment. It's now referred to as complex rehab devices. And I think one thing that's really important is the experts really needed to embrace a partnership with our participants in the process of recommending equipment. That if someone has lived with a disability, has an experience level, we needed to capture that information in individual interviews. That the intake process of what works with your current device was as important as identifying where you're having problems with your current device. Home visits have added a huge dimension on what's the environment of use, both inside the home as well as the surrounding neighborhood. Is it a hilly environment? Are the curb cuts not so consistent with code? What are the challenges that the wheelchair rider is facing on a daily basis? We recognize that therapists have a set of tools, whether it's literally a set of tools or a knowledge base regarding the equipment that could meet somebody's needs. But equally important, the participant has knowledge of their past experience and their desired outcomes. And it's only in a recognition of partnership, of the therapist having the ability to offer particular pieces of equipment as part of the solution, in combination with really respecting the participant's knowledge and their desired outcomes. We have a favorite saying that with joint participation in the process becomes joint responsibility in the outcome. So it's not the expert therapist telling somebody what they should use. It's really a collaboration of what is likely to serve the purpose in the environment the person wants to use it in. Move to the next slide, please. Next slide. So the picture at the bottom of your slide there. Oh, go back one for me. There we go. Thanks. If you look at the picture at the bottom of the slide, you'll see a display area that was purposely built to be exactly that. We wanted our participants to know that this was a consumer purchasing experience, that there are a large number of models, of products, devices, and when people come, quote, rolling in, they get a chance to see what could be. It's not just what they've been told is available. It's what do they think could match their needs. We work with rehab technology suppliers, and we really look to match the individual product recommendation to the functional need that the member brings to us. Early on in my work here at ICS, I was asked to see a woman with cerebral palsy who was propelling a manual chair quite effectively. However, she was 4 months pregnant and brought to the care team concerned that once the baby was born, how does one push a wheelchair and manage holding and or managing her child? And we very quickly came to the conclusion that a power wheelchair enabled her then to become an effective parent, as well as to be able to mobilize in both her home and community environment. Next slide, please. As much fun as it is to be a part of the recommendation of new equipment, to our members and participants, the most important thing is keeping what they have in terms of mobility devices and assistive technology in their home working was really an overriding need. So we created several mechanisms for maintenance and repair, and it's particularly critical if the equipment someone's using was individually configured for them. We need to know that it's going to be operating on a daily basis as consistently as your automobile is. So we have an on-the-road repair program where technicians with vans go to people's homes, and we like to address the problems that can be addressed in the home, fix the problem, replace the seatbelt, fix the foot pedal, keep the caster from falling off, and keep people moving. It's incredibly efficient. People really appreciate it. And needless to say, if your chair doesn't work, trying to get it someplace isn't really the most effective response. We have found that if we do provide people an environment for maintenance, they'll take advantage of it. So we have what we call our maintenance workshop. We like to think of it as Jiffy Lube for wheelchair riders. And it's the classic, if you address the squeaky wheel before the wheel breaks, you can stay functional. So once a week, once in our Brooklyn office and once in our Bronx office, we have a technician available, and our participants can either make an appointment to have a small problem addressed, or they can, quote, be roll-ins and get the technician to identify worn tires or a frayed cord and get the parts ordered before they have a fundamental breakdown. Yes.
Tina, I'm afraid due to time I need to break in here. We're having lots of people come in with questions, and I think the content you are providing is excellent, and I think we'll probably need to follow up some more in a different webinar. But I'd like to, at this point, open it up to questions, and so if the operator could give brief instructions for that, and then we'll proceed. In the absence of the operator giving directions for the calling in.
Sorry, hello.
Oh, yeah. Could you give the directions for calling in, please?
Directions for Q&A, questions
Yes.
and answers? Okay, I'm sorry. Thank you. Ladies and gentlemen, if you wish to ask a question, please press star then 0. You will hear an acknowledgement tone. If you're using a speakerphone, please pick up the handset before pressing the numbers. Once again, if you have a question, star 0 at this time.
Great, thank you. While we're waiting for the questions to come in, let me raise a few questions that came in writing during the presentation. There's a question from Heather Nugent at Prime West, and I think she identified an issue that is something that we've struggled in this field for over a decade. She indicated there was no reference to mental health or chemical dependency in this presentation, and I will add in many of our previous presentations. She says it's interesting this population has the highest percentage of mental health and chemical health issues. I know that's something we struggled with when I had a program in Minnesota. Rachel and Jean, can you just talk a bit about how do you work on addressing the behavioral health and chemical dependency issues that your participants are dealing with?
Sure. So we talked about care managers, and we talked about care managers as social workers. So we have, within our teams, we stratify both the members and the staff. So members who have behavioral health needs are managed by a behavioral health social worker. They are specialists in their area, and they will link them to the community resources since we don't provide the ongoing therapeutic support, but it is important to us that we have someone who understands this person's disease and condition. And I didn't get a chance to speak to this today, but similar to that, we have specialists in multiple sclerosis, in spinal cord injury, and as I said, behavioral health to address our members' needs. The second point that I'll make is I talked about harm reduction, and I use smoking as an example, but very often we have members who are using substances, whether it is marijuana or alcohol, and we do something similar with them. We try to get them into treatment. We do some crisis intervention and try to link them with services, but if all else fails, we do use harm reduction, so we can still provide them with care.
Thank you
very much.
We do have a question now from the line of Cheryl Paris. Your line is open.
Yes, hi. My question is about the senior aids. I would like to know exactly how does that mesh with, I know having different providers and different aides in there. Is that aide actually an employee of the company who goes out and assesses the work or the relationship between the other aides that are being placed in there by the LTSS?
Yes, they are an ICS employee. And you're right, because otherwise it would be very complicated to say they're from this agency and talking to another agency. So that they are an ICS, they're there as peer support for the aides and also for the members, but they are an ICS staff. So it's the same as a social worker going in or a nurse going in from ICS.
Oh, wow. Thank you.
Yeah, I'd say that is something that ICS is unique with nationally. They've been doing this for a couple of years on a pilot basis. I think that deserves some further attention in a future webinar because they've been able to capture the knowledge and competency of the people who are in the home with their members every day and in a very successful way. We've got a question here from Valerie Pearson at TMG Health. Again, I think this is for Eugene. Is the Braden information collected electronically or hard copy? And does your team have access to this information on a shared technology platform?
The Braden is available in hard copy. We have it embedded within our electronic care management system, so the information is available to all members of the care planning team and is used accordingly so that the intervention can be targeted to the exact risk factor that was identified during the assessment.
Thank you. Another question that we received is from Jennifer Barron at CMS, and she's asked, how do you measure success, and how do you know that you're achieving that success? And I think what's being referenced is the success, the goals that you've identified and the member have identified through the assessment process.
So one advantage of the 180-day reassessment is it's a built-in opportunity to look back on the previous 6 months, identify what was on the original problem list, what was the agreed-to interventions, what's the progress been towards to implementing those interventions, and ultimately what was the level of satisfaction for the participant themselves. I'll speak specifically in the rehab world. When we do our initial assessment, whether it's the interview, come in, see the person in the environment, we'll ask the question directly, what is it that you want to do that you can't do now? It may be, I've been spending too much time in bed and I want to be able to be sitting in the chair for several hours at a time. After delivery, we can do an inquiry back and say, how long are you able to sit up in your chair now that you have an appropriately configured device? So each care team targets the intervention that was highlighted by the member, and that's part of the 180-day reassessment.
Yeah, the only thing that I'll add is that we also look at hospitalizations that are prior. So what's happening to people outside of the long-term care services, and as we're talking about bridging the gap, how are they using the healthcare delivery system outside, and can we reduce that? So that's also an outcome we measure.
I think that's common in a lot of programs across the country. They identify the handful of preventable inpatient episodes, potentially preventable inpatient episodes, such as what they've talked about here, the pneumonia, the skin breakdown, and they track that in their claim data. And every time one occurs, they go back to the team and step back and say, could we have prevented this? And how can we prevent this from happening in the future? So there's a variety of approaches. We only have another minute or two left, and so I wanted to call everyone's attention to the survey link that's on the slide here in front of you. It's very important to us that we hear from you what worked, what you're still wondering about or needing to know. If you could just take a minute or two, we'd appreciate it. And then also feel free to email any of us that are listed with our email addresses at the end of the presentation here. Is there one last question online on the phone?
Ladies and gentlemen, if you have a question, press *0.
Okay, so in the absence of that, let me ask one last question that has really kind of come up throughout many presentations, and that is that the person says, I really appreciate the concrete risk assessment approach that you have described. It seems, though, the success is based primarily on the participant letting you know at first symptoms, earlier than in the past when they have needed to wait until progression before they are able to get the needed help. How do you get this early response from the participant?
So that's a great question. I will tell you in all honesty, sometimes we're successful and sometimes we're not, but we really try to invest up front, right, to develop a relationship with people, to engage in dialogue that says what's important to you, how can we help you, how can we be in service to you, and ideally we have that conversation before crisis. and to say this is how we can help, and call us when this happens. That said, it is an ongoing challenge. Some people are easily engaged, and some people are more difficult to do so. Once we can show our benefit, we tend to be more successful.
Yeah.
They'll come back.
Right. Relationship.
Yes.
And that's a theme we've been using through all the webinars. Thank you very much on that. I do need to wrap it up at this point. Many questions have come in. I just want to assure everyone that we will be taking these questions and responding to them directly or forwarding them on to our speakers. I think what we've learned out of today's lessons, especially since we were not able to get to the latter slide, that there's a lot of questions that people have about how do we actually in practice support people living their lives in the community. And so I would hope that we would be able to have an opportunity in the early part of next year to be able to provide some more of this information. So thank you all for participating. This link, a link to this presentation as well as all the other presentations are on the website. And as I said, we'll be responding to the questions. We have a break for a couple weeks here due to Thanksgiving, and then we'll be having 2 more presentations on Tuesdays in December, the 3rd and the 10th. So please look for the email telling you about these presentations, and I hope you can join us in the future. Thank you very much.